Okay, good morning, everyone. Welcome to the National Institute of Health and Care Research, Applied Research Collaborative, National Priority Programme, the Mental Health Implementation Network, also known as MHIN. Today, we're going to be speaking about the Patient Carer Race Equality Framework, also known as PCREF, and we're going to be exploring the role of system partners in driving race equity in mental health. Today is Monday, the 31st of March, and we're going to be speaking between 11 and 12:30 today. My name is Jason Grant-Rose. I'm the Patient and Public Involvement Lead for the MHIM program, and I'm going to be your host for today. Can I have the next slide, please? So we'll start with a few housekeeping things. So all delegates will be muted throughout the event. If you have any questions as we go along, we're going to have a dedicated section towards the end for 30 minutes to have questions and answers. So please do use the Q&A function at the bottom of your screen to put in your questions. And if you upvote by clicking the thumbs up button, your questions will be more likely to be answered. This event will be recorded and you can use enable captions if you need them. Again, that is at the bottom. And if you have any technical issues, please do contact our colleague, Michelle Harris-Tafari. The email address is there, or you can use the chat function and one of my colleagues will be able to pick that up as well. Next slide, please. So we'd love to have a bit of engagement on social media, if that's your thing. You can find the ARC South London at bluesky.social. You can also engage with others in the webinar, so you can use the chat window for any general points or technical questions that you may have. But do be reminded of, if you want to ask a question, please use the Q&A window to raise questions for the speakers. Next slide, please. So we want to ensure that this is an inclusive environment where open discussion can take place. So please avoid acronyms where possible, be respectful and allow room for constructive challenge. And after the event, share the information you receive, but do not reveal the identity of who said it without their explicit consent. Next slide, please. So we've got a real packed agenda for you today. So as I mentioned, I'm going to be doing a brief kind of introduction. Next up, we've got Dr. Jackie Dyer from the Mental Health Equalities Advisor, Chair of NHS England, and Husnara Malik, the Programme Manager for the Mental Health team. And they'll be speaking about the critical role of integrated care partnerships for the NHS England's Patient Care and Race Equality Framework. Next up, we'll have Dr. Owen Mears, Senior Policy Officer, and Kiara Hayes, Senior Equity and Rights Officer from the Care Quality Commission's assessment framework. And they'll be talking about assessing PCREF related development and performance using their assessment framework. After that, we'll have Kath Prescott, the project lead for MHIN, and Juliana Morimoto, ARC Greater Manchester. They've both been working with Professor Dawn Edge at the Greater Manchester Mental Health Equality, Diversity and Inclusion Research Unit. We'll also have Donna Franklin from ARC Yorkshire and Humber, and who has been working with Professor Scott Welch at the Sheffield Centre for Health and Health-Related Research. And they'll be sharing insights into implementing the PCREF Race Equality Framework across those two sites in Greater Manchester and Yorkshire and Humber. And then next up, we'll have Dr. Kate Alsop, who is a research fellow working at the Complex Trauma and Resilience Research Unit in Greater Manchester Mental Health Trust. And they'll be talking about the time to talk about staff trauma, tackling race-related harassment and physical violence recommendations and best practice. And as I mentioned, towards the end, we're going to have 30 minutes time for your questions and answers. So please do use the Q&A function in the bottom of your screen. Next slide, please. So about the Mental Health Implementation Network. So the network is a collaboration of service users, local communities, health and care providers, commissioners, and a range of regional and national stakeholders, including charities and local government. It is led by the NIHR Applied Research Collaborative for South London, and has been working closely with the NIHR Applied Research Collaborative for East of England, as well as the other 13 ARCs nationally. Next slide, please. So following a process, we were delighted to announce the following ARCs and local partners who were collaborating with MHIN to implement these interventions in their local areas. So today we're going to be talking about Project One. So this is all about improving access to mental health services for minority ethnic communities. And as I mentioned before, that was Greater Manchester and Yorkshire and Humber who were selected to implement the patient and carer race equality framework. Project Two, you had children and young people's mental health. This was set by East of England and the Northwest Coast. And they were looking at evaluating the implementation of parent-led cognitive behavioral therapy. For Project Three, you had integrated care protocols for substance use issues, mental and physical health problems. Again, this was Greater Manchester and Yorkshire and Humber, and they were selected to look at the implementation of alcohol assertive outreach treatment. Obviously, more information about MHIN and the projects can be found going onto our website. Next slide, please. So for me, I just wanted to kind of, take a bit of time, 5 minutes or so, just to really think about the importance of improving access to mental health services for minority ethnic communities. So I'm going to give you kind of a brief summary of my own kind of trajectory, really. So next slide, please. So my journey started off, I always honor my grandparents who are no longer with us. And actually I went to see their grave yesterday. But they came from this beautiful island called St. Lucia, and they came to the UK around the late 50s, and they, classed as part of that Windrush generation, really. And I suppose for me, it was always kind of filled with like fond memories, but obviously it was bittersweet as well. Next slide, please. So my grandparents settled in a place called New Cross. So my mum was born here as well. Most of my family were here, some from a big Caribbean family. And around the time, so this was before I was actually alive, but they had this thing called the Battle of Lewisham. So New Cross was really kind of one of those areas that had a real issue with race. And it was very complex and complicated. And so when I was growing up, we were kind of growing up in the 80s of the backdrop of like the New Cross fire, things like that. And yeah, just growing up in these environments in Southeast London, for colleagues that are not familiar, was very kind of fraught with knowing that you were being a racialized body before you even understood what race was really all about, really. Next slide, please. And so for me, I thought that I would have escaped mental health difficulties. So unfortunately, that wasn't to be. So my first episode happened when I was in this lovely place. This is Rio de Janeiro. And unfortunately, at the time, because of maybe it was a stigma, but maybe just lack of understanding or lack of access, I didn't really appreciate and understand that my issues that I had in terms of seeing things and hearing things that wasn't really other people could recognize, that was the start of a mental health problem. I didn't really understand how to access services at that time. Next slide, please. So again, I love traveling. So this is one of my things anyway, but I ended up going traveling again to this lovely place. So this is Czechia in Prague. And again, I had a second episode. And at this time, I actually ended up singing and dancing at the airport. I was, apparently it's not the done thing to do. So I was taken away in an ambulance and actually brought into a psychiatric hospital. And I'm not going to go into the details, but it's probably one of the worst experiences I've ever had in my entire life. But even at that point, I still wasn't really appreciative of the fact that it was my mental health causing me these problems. I just thought it was other things that were happening. Next slide, please. And again, so when I came back to the UK, I had a third episode, and at this time I ended up in Sussex. So I was in Eastbourne Hospital for a couple of days, and then I was moved to Worthing Hospital. And actually, at this point, it was because it was my third episode, and obviously I'd been, brought into the system on a Section 136 for colleagues that know about that, and then had some time to really digest and understand what was really going on. And fortunately, to be fair to Sussex Partnership, they actually gave me the space and time and support that I needed to actually come back to reality and to try and make sense of these kind of unusual experiences, really. Next slide, please. So for me, I've been very fortunate, so I have to acknowledge this. since my episodes happened in 2015, so it's about 10 years ago now. I've been very fortunate enough to have worked for a number of different organizations, but I'm just highlighting these here. So at Sussex Partnership, I was an expert by experience, which meant that they actually helped me to kind of go along to meetings, find my voice, and actually helped me to kind of understand how the mental health system worked. My first proper job I got was with the Department of Work and Pensions, and obviously it's in the news currently. But at the time, we were tasked with training the work coaches to understand mental health better to support the people that were coming into the job centres. So we were covering 14 job centres across South London, and I trained over 500 colleagues across South London to understand mental health a bit better. After that job finished, I was on a research study in Manchester. We were looking at the ethnic inequalities within severe mental illness. So we did that up until the pandemic. When the pandemic came along, I had to find another job actually. So I was unemployed for about 3 months. And then I got a job working for the same early intervention service that I'd used previously in Sussex. So I worked there for 2 years. And then more recently, I came to Camden and Islington, where I was working as a peer coach for 3 years, alongside other activities. But for me, it's just around making sure that we understand how the system can enable people with, severe mental illness problems and experiences to be able to kind of make a meaningful contribution using their experience, really. Next slide, please. So for me, it's all about finding meaning and purpose. And what I'm hoping from today's colleagues who will be speaking about the patient care and race equality framework is how we can enable other people to find meaning and purpose and create this collective joy that we want to see in our lives, really. So mental illness doesn't have to be a burden, but it can be an experience that people can flourish from afterwards. Next slide, please. So without further ado, I'd be delighted to welcome Dr. Jackie Dyer and Husnara Malik, who will be speaking with us next. So over to you, please.
Thank you, Jason, for sharing such a beautiful message and story. Hello, everyone. My name's Husnara Malik. I work for NHS England. I'm the National Lead for Advancing Mental Health Equalities, and specifically within that, the lead for implementing the Patient Care Race Equality Framework, supporting Dr. Jackie Dyer, who you'll be hearing from in just a moment. So just like Jason, I think it's important to set the context a bit in terms of how this all started. So NHS England, they have a long-term plan which sets out how to tackle our greatest health challenges, including closing the gaps in mental health services and addressing health inequalities specifically for mental health services. We're proud to say that in the height of the pandemic, NHS published our first ever Advancing Mental Health Equality strategy, and this was really about calling upon on all mental health services to take concrete steps to fight stigma and inequalities across the health sector. And the strategy has really become the bedrock in identifying which population groups continue to be poorly served and how to put in place mental health interventions on what we need to do to improve access, experience and outcomes. The strategy itself focuses on 3 key domains. One is around supporting local health systems to advance equalities. Second one is around improving quality and use of data to inform decision making. And third, it's about creating a diverse and representative workforce which is equipped with the capabilities to achieve change. What we know that one of the key interventions within the strategy is, of course, the Patient Carer Race Equality Framework. And this was supported by the recommendations under the Mental Health Independent Review in 2018 and a setup of the Mental Health Act African and Caribbean Group to support the aims of the review, focusing on the inequalities faced specifically by racialised and culturally and ethnically diverse communities. And that's where NHS England, of course, agreed to take forward the implementation of the Patient Carer Race Equality Framework. I'm going to pause there and now pass it over to Dr. Jackie Dyer. Thank you.
Thank you, Husnara. There's some slides here that we've got that. So you will have heard Husnara set out the wider context, in fact, the policy, statutory, legislative kind of like context of the development of the patient and carer race equality framework, emerging as a recommendation from the Mental Health Act review, but actually having an earlier history within a review of adult inpatient mental health services called the CRISP Commission. And that was where the idea of the patient and carer race equality standard first came to my mind as a result of that and my own lived experience, because I just couldn't understand why the voices of patients, carers, and communities wasn't the most important source of feedback to help service improvement for racialized communities. Next slide, please. And why I'm so adamant about this was my own lived experience of 3 siblings with severe mental illness and growing up with my mother in and out of hospital with mental health challenges and receiving ECT treatment. And so there were periods where my mum was like, felt really unavailable. And my siblings, since I was in my late teens, there started to be periods where my siblings had real crises pertaining to their mental health. And that's been ongoing for 30 odd years. So for me, my experience of mental health service provision has been very traumatic. It hasn't actually really supported the needs of our family. And I was really concerned, if this is what's going on for my family, what's going on for other families? So I recognizing that we lived in a system, and so started pursuing an academic route to try and make understanding of that, and working in a range of services to really understand what is it that we're doing here that could better serve my family and serve communities when they're at their most vulnerable. I've lost 2 of my siblings, unfortunately. One at the age of 53, Barry, and the other at the age of 41. As far as I'm concerned, mental health services fundamentally fail racialized people. They should be here now, they're not here. And more recently, my aunt went into hospital, diagnosed. I mean, she has a long-term mental health challenges. She went in because she stopped eating. She was supposed to be being fed by a tube. On this occasion, they never put the tube to feed her. They put it in her lung, it killed her. You know, I tell people this story, these stories of our lived experience, and people are like, shock and horror. But actually, we're not even shocked and horrored, because this is the reality of the lived experience of a racialized body. We weren't even surprised because we know that this is what happens. We were hurt and we're angry, but we weren't shocked. And that says a lot. Next slide, please. And that's some of the things that really informs you about the urgency with which I and my allies are attending to this agenda. We know that racialized communities often are dehumanized and therefore don't receive the most excellent mental health care when they're at their most vulnerable, which is actually what is required of this of mental health services. So let's look at some of the features of how mental health is experienced from a historical context in terms of our policies and the care that is received. Systemic racism, as many of you know, structural racism, systemic racism, institutional racism is absolutely entrenched within our society, and all of our policies, procedures, cultures, all reinforce the reinforce the way that racialized communities are attended to, because if policies are infused with racism, then the outcomes of the implementation of those policies will be a differential experience. But no, we're not very aware of that in the way that we need to be. Hence why the PCREF is so important. If we really want to attend to these injustices. There are, for one feature of that, of systemic racism, is around funding disparities. So how resources are deployed, creating significant barriers for racialized communities seeking mental health care. So, for example, limited availability of culturally competent providers and longer waiting times. So there's a cost of racism. There are barriers to access, and this is a key thing, but we also need to think about what are people accessing? When there's barriers to access to mental health services, and why don't people want to access those mental health services at an earlier juncture? Because the services are stigmatized, or they themselves as communities are stigmatized. There are fears, there are stereotypes, they're not really being heard. Why access that kind of service for mental health when it's infused with all these issues that create barriers to access? Next slide, please. And so the consequences of dehumanization in mental health services, it has an impact on patient trust, family trust, communities trust. The issue around trust could not be more significant. When you think that actually services are called mental health trust, and the issue is about trust, then you look at that and you really start asking the question, how can we ensure that services are trustworthy? Because if they're not trustworthy, why would we engage with them? So that is really very critical, and continues to be one of the most serious features of why people won't engage with services, and indeed with public statutory services per se, because they don't trust them. So we end up coming in at later parts when our issues are more acute, and actually the system operates in an extremely coercive way at that juncture. And racism essentially makes us sick. You cannot be living in this society without, as a racialized body, and not feel the impact of daily microaggressions, of daily belittlements, of daily want something for a white body and a differential treatment for you. And you're conscious or not conscious of that because it's normalized. And these are some of the insidious ways racism manifests itself and undermines our ability to trust services and the people who make up those services. And then there are cultural misunderstandings, and the importance of cultural humility, not necessarily just about cultural competence that is in the zone, but actually a commitment to ongoing learning, not a fixed point, or I'm really competent about one culture just now and then it's fixed. No, a commitment to ongoing learning and development, which I think some of the other terms around culture sort of reveal: cultural sensitivity, culturally appropriate, cultural safety, cultural humility. We have to think much more broadly than what we actually do when it comes to the racialized experience. We get into these fixed boxes and call it George. It isn't like that at all. The level and the depth and the magnitude of this scale of challenge means that we've got to really put our shoulders to the wheel and keep going in terms of our learning and our development and our evolution in order to contend with structural racism that's been going on hundreds and hundreds of years. And we'd be really rather naive to think that a couple of interventions overnight is going to resolve it. That would be utterly deluded and really quite questionable in the realm of mental health services, when actually we're there to support people when they are experiencing real pain and vulnerability. And the long-term psychological impact that's also infused with what I've been speaking about, and why it's so urgent that we really attend to this in a way that's collective, and there's contributions from a whole system approach at every level. Anything less is inaction in the face of need and a clear indicator of systemic racism going on with impunity. That's what we are living with right now. Next slide, please. So you will see the impact of societal unrest, the riots most recently, and there is obviously an urgent need for reform. And so we've got the Darzi report that speaks to some of the levels of how, and an opportunity actually about how at each level, national, regional, ICB level, local, we can take accountability around implementing this improvement. The Mental Health Act bill, we're working very closely with our colleagues in the department. More recently, we held a special roundtable for the House of Lords, looking really closely at mental health disparities, racialized disparities, and how to address that. And you may well be aware that the United Nations Committee on Racial Discrimination, August last year, spoke about the Patient and Carer Race Equality Framework, which obviously you all know is an anti-racism framework. They spoke about that to say that that was the Equality and Human Rights Commission only could name one intervention that was dealing with racism. What was that? The PCREF. I think that speaks volumes in this here country. And really acknowledged for its systematic approach. Next slide, please. We've talked about the journey. We've got pilot sites. We started with 4. We're now on 18. We're spreading right across the country at pace and with real commitment, which is really quite the right thing to be, reflective of the scale and complexity and magnitude of this issue. Next slide, please. And we've made sure that we've systemized where the attention to and the perspective is in order to sustain this movement, this this race equity accountability, working with the culture of care standards, the inequalities legal statement for NHS England, embedded within the NHS standards contract, the CQC inspection process, which you will hear of just shortly, the EDS delivery system, Core 20+5, Triangle of Care. We've embedded it in every part of the system so that actually there is this collective impact, collective ambition, collective accountability that is visible to the constituents that are being served, not something in some closed over there, sort of hidden away from view, but actually everybody is showing what their contribution to actually making this a reality in our lifetime is vital. Next slide, please. And this is what it looks like. Leadership and governance, part 1. Patient and carer feedback mechanism, part 3. And the organizational competencies, part 2. Cultural awareness, staff knowledge and awareness, partnership working, co-production, workforce, co-learning. These are the key ingredients that in order to take the data from part 1 and the data from part 3 and use that as collective insight, because it's qualitative and quantitative data, use that as collective insight to then look at each of the services and working with lived experience, service users, carers, communities, and the workforce and the leadership to look at where the changes need to be made and then how we are going to make those changes and hold ourselves accountable for changing the narrative of what the data is saying. Currently, it's the most coercive and the most negative and detrimental for racialized communities, with attention to working on these services in the way that this system allows you to really get creative, really get dynamic, really be accountable for your work, changing the narrative from what it says now to something completely different, so that actually we're moving towards services that are trustworthy, and that people in the communities from racialized backgrounds will be able to say, you know what, go to those services, go early, because they really are going to support you in your recovery, your healing journey, because they're not stigmatizing, they're anti-racism, and they're not oppressive, and you will be supported and healed when you are at your most vulnerable. Imagine people will be running to the doorways of services like that. Currently, they cannot. It's scary because you may well be killed, because that's what happens to the racialized body. Next story. Obviously, this doesn't happen to everybody. Some people have a good experience, but those good experiences are rare. They are not the common experience for racialized communities. Next slide, please. So I think that I've sort of come to time here, and I want to make sure that the next participants are able to go through their slides on time. I think this is my time now. Next slide, please. And you will be receiving these slides. So how can you really support with the implementation of the patient and carer at an ICB level? How is your organization ensuring compliance and delivery of this anti-racism framework, of its implementation? And what key data is currently being reported at an ICB level? And what are the challenges that need to be further explored? Next slide, please. Thank you very much. There are resources available to support you that are also attached to this presentation. And thank you for your time.
Thank you so much, Dr. Jackie Dyer and Husnara Malik. Wonderful presentation. Thank you so much. Yes, we'll now move on to the Care Quality Commission. Do you want to come on screen, please? Thank you.
Hi, Kira. I'm just at a point. Can you see my video? I'm not sure if it's showing or not.
I can't see you, Ewan.
Okay, just bear with me. Are you all right to start, Kira? I just try and sort out the video. Is that okay? Thanks.
Yeah, can I check? Are you sharing the slides, or are we leading that?
No, the slides are being shared, Kira.
Oh, okay. Right. Thank you. I'll kick us off things while Ewan gets his camera sorted. Good morning, everybody. Thank you so much for the opportunity to come and talk to you kind of about what we've been doing at the Care Quality Commission. We really are in support of the PCREF and its aims, and have been working closely with Jackie and the team and the wider pilot sites now for a while. So it's great to be here to kind of talk about the progress we're making and kind of our ambitions as well. I'm just going to get started, Ewan, because I'm doing the first part anyway. So next slide, please. So I'm sure, hopefully, a lot of people here are already aware of the Care Quality Commission and what our role and purpose is, but just to kind of ensure that we've all got that same foundation level. At the Care Quality Commission, we are England's only health and care regulator. We make sure that health and care services provide people with safe, effective, compassionate, high quality care, and encourage care services to improve as well. It's a bit of a dual role. And you may be familiar with our 5 key questions, which is that we ensure services are safe, effective, caring, well-led and responsive. And our kind of legal backing for that is under the Health and Social Care Act and derived from our fundamental standards. We also, which people may be less aware of, we also have a monitoring duty under the Mental Health Act, where we have our reviewers and our second opinion appointment doctor specialists as well, who ensure and help the protection of people whose rights are restricted under the Act. So we go to places of detention and visit people who are deprived of their liberty to ensure that the services who are carrying out their duties under the Mental Health Act are doing so properly. Next slide, please. So why do we have a role in supporting PCREF? What we're doing here today and why? So I've already gone over our purpose, which is about those 5 key questions and really supporting and improving care. And we firmly believe that PCREF is a very important tool for us to play our part within the system to achieve our purpose and then the wider shared objectives across the system as well, which is equitable care for all. We do believe that safe, high quality care can't be done without care that is rights respecting. And of course, we know that there's inequalities in the way different people or different groups receive care. So again, we believe this is a very important tool. In 2021, we also updated our strategy, and a key pillar which runs across our strategy is our commitment to tackling inequalities and protecting people's human rights. So again, this very clearly fits with that. We are also the largest member of the National Preventive Mechanism. The National Preventive Mechanism is a collection of bodies. It's international, but in the UK there are 21 bodies. Other ones may include the Prisons Inspectorate and so on. And we have rights to go to places where people are deprived of their liberty and to prevent ill treatment and torture. And the key part here is prevent. So we do that through the way that we monitor under the Mental Health Act, and we inspect and assess under the Health and Social Care Act. And I think there's a really clear link with PCREF there as well, because as Jackie spoke of, dehumanisation within mental health services and across the pathways can absolutely be rife. So doing all we can to prevent ill treatment and prevent that dehumanisation through tools like the PCREF, again, is very much us playing our part. And also, from September 2024, CQC has prioritised becoming an anti-racist organisation. We are absolutely at the beginning of our journey on that, but we are very clear that we stand against racism, violence, aggression and abuse in all its forms. And we are doing work to tackle that internally, but then also across all our external functions. And there is such a clear link with the patient and carer race equality framework there. We want to make sure that what we're doing and how we act is in line with the expectations that we have of services and providers. So as we develop this work, as part of that, we are absolutely aiming to increase the confidence, humility, competence of our own workers, so they can, when they're out there and doing their role, they can support initiatives like the PCREF to the best possible extent. Next slide, please. So like I said, we've been on a long journey now with NHS England, Husnara, Jackie, and the rest of the pilot sites. We began to map the patient and carer of race equality framework to our assessment framework late 2022, early 2023. And through a series of workshops and communications and engagement, we felt at the time that the patient and carer race equality framework was so broad and so comprehensive, but if we were to choose some quality statements, quality statements is how we assess providers. We believe that at service level, it fits best under responsive, about ensuring that services and trusts provide equitable experiences and outcomes. And then through our well-led inspection, so that trust level, we felt that it most neatly fit under well-led shared direction and culture. But we do recognise that PCREF is very broad and is very comprehensive, but this was just kind of where we started at. Back in 2023 to 2024, we also developed interim guidance internally and published it externally as well. And that what we've done is we've taken it kind of in line with how the PCREF has been launched and developed, and kind of that NHS England's own vision for it, which is allowing that embedding period. So we haven't included it within our reporting and our assessments and judgments yet. We've supported our inspectors and our assessors to take a more encouraging role, asking questions about it and so on up until this point. We uploaded training onto our internal website, utilising NHS England's fantastic videos that from when they visited Birmingham and Solihull, etc. So we've taken some of those and we've shared them with our internal colleagues on our learning site. We've been vocal through our a lot of our engagement channels. So we've released blogs. Our senior leaders have been very, very vocal about our role in supporting PCREF and its aims. We did a joint blog with NHS England. And again, we continue to use our independent voice. For the last few months, our monitoring the Mental Health Act reports, we have consistently mentioned the Patient and Care Race Equality Framework. And when we refreshed our human rights approach, we also spoke and referenced the human rights approach and the Patient and Care Race Equality Framework and the dehumanisation of racialised people within mental health services. And we continue to socialise and mainstream PCREF across CQC because it's so fundamentally important for people to see the PCREF not just as another framework, but it's something that is intrinsic to the work they do. So we're finding all opportunities that we can to really get it embedded across our organisation. Next slide, please. Ewan, are you back?
Yep, I'm okay. Hopefully you guys can see me now. Sorry about the technical problems. And just before I begin, I just want to say it was a really nice introduction from Jason, but I'm not a doctor. I haven't just got a PhD over the weekend, although that would have been nice. So just want to correct that, make a correction for that. So thanks, Keir, for starting the presentation. I just want to talk a little bit about what CQC have been doing since we published our last interim guidance on PCREF and what we hope to do very shortly ahead of the launch of PCREF as of the 1st of April. So we have been taking an evidence-based approach to reviewing how we can produce the best operational guidance possible for both our operational colleagues, but also to give a bit of an indication for providers as well about how we're approaching evaluating use of PCREF as part of our overall inspection findings. So we have been working closely with NHSE to review the findings from the PCREF pilot sites, which have been ongoing for quite a while now. We've been looking at what's been working well for some of these services and what hasn't been working well, and thinking about how that fits in with our assessment framework so we can provide the best guidance possible for operational colleagues. We've looked at data from inspections that we have carried out and also from our Mental Health Act reviewer visits. I'm not too sure if a lot of people on the call know too much about this really important function of CQC. So it sits outside of the Health and Social Care Act, our responsibilities under that bit of legislation, but it's very much linked to making sure that the Mental Health Act itself is being carried out in line with the Mental Health Act Code of Practice. So we have Mental Health Act reviewers who go out and conduct visits, and then they will write letters of recommendations to the providers and share that information with our inspection teams. And we kind of work in tandem. So that's been really useful, and we trialled a really great initiative, which my colleague Jackie Wilson, who's just recently retired and isn't able to be on the call today, was really instrumental in setting up. And this was about when the Mental Health Act reviewers go out, their primary role is to speak to people themselves who have been detained under the Mental Health Act, and we were able to incorporate into the question of the moment, it's called, a specific question about PCREF over the last couple of months, and we've been using the responses to help write what we think will be the most helpful iteration of the guidance. We're really lucky to link up with MIN, Mental Health Implementation Network, and we've been sharing some information with them and Husnara NHSE, and we're hoping to use that information for our forthcoming guidance to be able to ask sort of really the most helpful questions to be able to understand the experiences of people and what the impact of PCREF is for them. Is it helping improve their experience, or is it highlighting areas which CQC as a system partner can help to intervene and effect any necessary changes? And we're looking at the PCREF findings from the 1st of April to specifically inform our formal judgments of services and our reporting and our formal action. Yeah, thanks, Jason. Sorry, we're overrunning. So if I could just have the last slide, please, the next slide. So just really quickly, what we're doing post-publication, we're hoping this guidance will come out about the end of April, beginning of May, is that we're working on comprehensive training for our own internal staff to support the practical understanding of what PCREF's objectives are and what good might look like in that space. And we're hoping that we will actually build it into our formal induction process for all CQC new starters specific to the mental health space. We are looking at actively continuing collaboration with external stakeholders. We've set up a workshop for early April with some other system partners, including community groups, which we're really keen to engage with. And there are some wider bits of work about integrating PCREF into our Mental Health Act activity and the Code of Practice alignment. And we're currently scoping application, the potential for application to our approach towards PCREF through our ICS and local authority functions, which I think, if we're looking at this in terms of sort of a holistic whole systems approach, those capabilities and responsibilities that CQC now has, I can see we have a question earlier which was talking about ICBs. We're hoping that we'll be able to build an evaluation of PCREF into those functions as well, to really help us to use all of the levers that we have at our advantage to help support PCREF and make sure that it's being used to the best effect. So what this means is that we're hoping there'll be further iterations of guidance and resources based on the ongoing evaluation of relevant data. We did leave a space for questions here, but I'm hoping that we might be able to take any questions for CQC at the half an hour at the end. And there are two further slides, which if I can just ask if we are sharing the slides that people take notice of, because there are a number of ways that people can contact CQC, and we're really keen to stress that on the call today. Is there are a lot of ways that we're asking. We've got a specific team set up so we can monitor emails. So if you've got any specific queries about the policy side of PCREF, there's an email address up there. But anyone at all can contact CQC and raise any concerns you have, particularly around PCREF, via a number of methods, which is on this slide and the next slide. And so, yeah, please do reach out and just come and talk to CQC if you've got some concerns about PCREF, because we're very much here to support it. Okay, thanks, Jason. Sorry if we've run over time there.
No worries. Thanks, Ewan and Kiara. A brilliant presentation. And I love that whole system approach that you mentioned. So thank you for that. Next up, we've got the implementation sites. Kath, Juliana and Donna, do you want to come on, please?
Hello. Okay, I'll start us off then. So I'm Kath Prescott and I am the lead for Project One. And following a short introduction from me, you'll be hearing from my colleagues Donna and Juliana, who are our lead researchers. So the NIHR Mental Health Implementation Network commissioned research to understand and evaluate strategies for implementing the patient care race equality framework under Project One, improving access to mental health services for minority ethnic communities. Teams situated in ARC sites in Greater Manchester and Yorkshire and Humber have been working with system partners, including NHS England's Mental Health Equalities Programme, to understand practices that strengthen or hinder implementation and develop implementation insights and tools that will provide focus and clarity on exactly what steps are required to improve outcomes for people from racially minoritised communities. The research is focused on learning from community and voluntary engagement systems to support racially diverse community partners in co-creating solutions, understanding and leveraging existing quality improvement infrastructure for effective implementation, and identifying evidence-based measures for assessing both the witnessing and experiencing of racially motivated discrimination and harassment. Some of the tools that are currently in development are a data dashboard specification, and this is looking at inclusive leadership, mental health inequities and workforce inequities. It aligns to the NHS Equality Delivery System and the NHS England Statement on Information on Health Inequalities. In this way, supporting ICBs and NHS trusts and providers to pay due regard to their duties, both under the Equality Act and the National Health Service Act as well. Also been in development is an audit tool, and this audit tool is linking activity to clear outcome measures, and again providing ICBs and NHS trusts and providers with a roadmap to implementation. And the important thing there is really looking at how we link the activity to clear outcomes and improving those outcomes. and also the development of logic models. So this is looking at identifying the specific activity that then looks to improve outcomes. I'm going to hand over in a minute to my colleague Donna, who's going to speak about the work that's been taking place over in Sheffield, working with community partners to co-create a series of process evaluations to help inform those logic models. Following this, Jules, my colleague working over in Greater Manchester, is going to introduce the scoping review that is underway to identify what evidence-based measures are available to assess the witnessing and experiencing of racially motivated discrimination and harassment. So I'm going to hand over to Donna now.
Thank you, Kath. Hello, everybody. I can see we've got, what, 112 people on the call. Great stuff. Okay, so can we move the slides along a little bit? Yeah, we've kind of... Right, so as Kath has said, I've been working in Sheffield and conducting a implementation evaluation. And if you just look at the bottom part of this slide, I have been undertaking a process evaluation, which has involved 4 different activities that Sheffield Health and Social Care have told us that is part of their PCREF delivery plan. And I'll just skip you through them. The first one, the main one, well, the first one is they're trying to improve data collection of protected characteristics, namely racialized communities' data collection. The second, they have a specific restrictive practice strategy, which is aiming to reduce restrictive practice and to increase the use of the least restrictive practice nursing care. And then the 2 other community-based ones are to increase the pathways into care for racialized communities, and also to look at culturally appropriate advocacy on inpatient wards. So for about 6 months, I've been following these 4 active PCREF activities. Can we move on to the next slide, please? So here we have the 4 activities in the boxes that I've just mentioned. And these are how they kind of sit around the PCREF framework. So if I just give you a quick overview of the one on the bottom left-hand side, the improving data collection of protected characteristics. So what they're actually doing for this one is that they've created a bespoke data package, and they are piloting this with 6 different sites, different teams within the trust, and they are using a behaviour change theory, the COMBI behaviour change theory, to try to identify the barriers to why members of staff are feeling potentially challenged to collect patient data relating to race, identities, and so that is that package. And I just wanted just to show you the logic, one of the logic models, which I am creating. I'm creating logic models for each of these 4 activities, but I just wanted to show you the logic model for this one. And I apologize, it's really small, so please don't try to read the slide, but I just wanted to show you what the logic model looks like for this improving data collection of protected characteristics. So can I have the next slide, please? So this is it here, and I just want to point you to the diamonds. The diamonds are actually the actual interventions that they are doing. So I just want to just read out to you the top line. So we have assumptions, interventions, intermediate outcomes, rationale, and these are the steps that I tried to extract from the implementation team to understand what's the logical thinking of how they're going to move from the activity to the actual outcome and the impact, which is the tick on the right hand side. So using the COMBI behaviour change model, the idea is to produce the opportunity and to improve staff motivation and their capability to actually engage with patients, to collect racialized information, because currently SHSC have a deficit of around about 40%. And as we know, without this key information, services, they can't create services that people feel able to access. So I just wanted to show you the first logic model that I've created, and there are 3 more to come, and then hopefully we're going to create a larger one, which will be the main deliverables back to the trust. Okay, and that's my bit. Thank you. Am I handing back to Kath?
I'll take over from here.
Okay. All right. Hi, Juliana. Great.
The assessment of both the experience and witness of racial discrimination and harassment is essential to understanding its impact on service users and carers. Identifying validated tools is critical in shaping future research, interventions, policies, and the implementation of PCREF. Our scoping review aims to map the landscape of measures that are currently being developed for assessing this experience or witness of racial discrimination and harassment. Following the PRISMA framework, we are identifying and analyzing studies that develop, use, and validate these measurement tools. To be included, studies must be a peer-reviewed article. It could be gray literature or any report published in English, and must have physical or mental health implication. Our search took place on PubMed, PsycInfo, Scopus, and CINAHL. So far, we've screened about 12,796 studies. We've narrowed this down to about 4,214 at the title and abstract level. And then we identified about 54 for full text screening, out of which we've selected about 15 studies for qualitative synthesis. Some of these measures that we found include things that assess gendered racial microaggressions, online racism, racialized religious and sexual discrimination, discrimination in acute traumatic instances. So for example, the experiences that an undocumented migrant or survivor of racialized domestic violence might experience. It's also important to keep in mind that all 15 of the studies have been based in the US as well. So a lot of the development of measures are taking place in the US, and we haven't really observed any really developed in the UK. At this moment, we are in the extracting and aggregating data process, and we aim to complete our scoping review by the end of April. And we have further plans to secure additional funding so that we can take this further into a systematic review. And that's it for me, and I'll pass back over to Kath.
Thanks, Jules, Donna, and Kath. Wonderful presentations hearing from the sites. So our last speaker today, we're going to have Dr. Kate Alsop. Are you there? To come on, please.
Hi there. Thank you all. So I'm going to be talking to you about some of the findings from the staff time study, which was a research study exploring the experiences of staff working on acute mental health inpatient wards. So next slide, please. So the study was funded by the National Institute of Health Research, and it ran for a year and finished at the end of 2024. So broadly, the aims were understanding experiences of staff on working on acute wards. So what kind of distressing experiences they had and what kind of support they were receiving for those. looking at what helps or gets in the way of staff accessing support for those experiences. And in particular, what helps and gets in the way of staff from minoritized groups accessing support. So that was around ethnicity, sexuality, disability, neurodivergence, and so on. So it was a big, complicated study. So I'll focus today on just highlighting some of the findings around the experiences of staff from racialized communities. So next slide, please. So what we did, it was a national study, and we had a fantastic research assistant, Emily Harris, who interviewed 43 staff working on acute wards. We particularly wanted to speak to people who we thought may struggle to access support. So we purposefully sampled to get a really good range in terms of demographics, but also job roles. So staff who are permanently on the ward for their work, but also staff like admin, bank and agency staff, people working for estates and facilities departments, and domestic staff who perhaps aren't permanently on the same ward, so may have a different experience of support. We also interviewed 10 of what we called senior stakeholders. So these were experts in national or regional policy, staff support, and equity, diversity and inclusion. So next slide, please. We've got lots of demographics from the people who took part, but just to, in the interest of time today, here's a quick overview in terms of the ethnicity breakdown for the ward staff that we interviewed. And on the next slide, we've also got the ethnicity breakdown for the 10 stakeholders who we interviewed, just to give an idea. And next slide, please. So in terms of findings then, in terms of causes of distress, I'll just go through these briefly. We developed kind of 3 themes around what was causing distress on wards. So these fell into incidents, so typically kind of violent or aggressive incidents, persistent stresses. So these are the kind of either low level, ongoing kind of day-to-day experiences that staff are experiencing all the time on many shifts, or things that were much longer term in terms of their impact. So for example, allegations and then consequent investigations for staff. And then finally, work-based issues and pressures. So for example, kind of systemic issues, staff shortages, that sort of thing. And just to highlight that you can see how the experiences of racism and discrimination are really compounding these already very difficult experiences for staff from racialized communities, whether that's from racially motivated assault, experiencing racism on the wards, verbal abuse and so on, allegations being more likely to be experienced by people from racialized communities, and then microaggressions and discrimination from colleagues. So all of these are compounding the difficult experiences for staff. Next slide, please. So I'll just read out some quotes, some of the experiences that illustrate some of the different aspects that we found in the study. So highlighting the frequency of racism and racial abuse on the wards. A nursing assistant in the top left says, "There's racism all the time. It's basically every night. Black staff are being accused a lot, like every month, of sexual assault." And then on the top right, highlighting the differences in terms of kind of career development and inequity between staff and staff in more junior positions versus kind of management and senior leadership. The nursing assistant says, "It shows also in the career development of the BAME community. It shows in the gap between positions. It shows in the level of people who are leading and those who are the supers." And then finally, at the bottom there, just highlighting the lack of response to racism and racism going unacknowledged on wards. The junior doctor says, "With every racist remark that a particular patient would make, the only thing that staff were supposed to do was write an incident report to the police, and that was just another form of paperwork for the staff. There was nothing else. Nobody would talk to them about it. Nobody would get back to them about it." So if we go on to the next slide, please. So I won't go through this in detail, but just to give you an idea of the different types of support that people received, or that people spoke about that they're receiving at the moment. So in terms of support following racism, you can see from that quote before, unacceptable behaviour is often not acknowledged by colleagues, by staff at the end of a shift, and therefore people kind of not offered that support, and that really in general participants had shared a perception that the NHS and that trusts were not doing enough to support staff with protected characteristics or to address systemic discrimination. And just to pull out a couple of other ones in terms of support that people have accessed outside of the ward, quite a few participants spoke about the really positive support that they'd received from networks that were specifically to support staff from racialised communities. So, for example, international staff networks and race equality networks, and those being so important as a kind of actually having safe spaces and receiving support from peers, from other people who got their experiences and validated and recognised those experiences. So it really shows the importance of having support that does exactly that. And just to highlight peer support as well. So this was often really relied upon by staff. It was often the most consistent source of support. But again, just to flag how there would be certain, how many staff members won't be able to access that kind of peer support where they may not be within that main staffing group, either because of their job role, by being bank and agency staff, for example, or where there's discrimination and racism amongst colleagues, where that they may not be able to lean on that peer support. Next slide, please. So Jackie spoke of the collective accountability just being absolutely crucial. So that goes from kind of ward staff working on wards, managers, senior leadership, and that just being absolutely essential in terms of responding and supporting staff. So I'll just run through some of the recommendations for managers and trusts. So if we pick out the column in the middle around responding to identity-based abuse, recommendations that came from our data were around actively promoting ward cultures, so that acknowledge the distressing impact of racism, of homophobia, transphobia, and other identity-based incidents, because actually naming and validating those experiences is really crucial. And then beyond that, actually encouraging staff to report those incidents, but also to label them as identity-based, as racially motivated, for example, because this means that we can collect that data, and then beyond that, that data should be kind of monitored in terms of frequency, patterns of incidents. So it's about that kind of actually following up when things happen, making sure that they're reported, making sure that then the staff who have reported them know what's happening, that they're offered support in response, and that they know what next steps will be taken. But then from a trust or organisational level, that those patterns and incidents are discussed at NDT meetings within the ward, but also then higher up in the trust so that they can be acted upon. Next slide, please. So then in terms of recommendations for trusts, I'll just pick out a few of these. So lots of consistency with the PCREF here, so increasing diversity at senior leadership levels, and again, modelling that culture that is naming and acknowledging issues, particularly acknowledging the impact of structural discrimination and racism that is happening within wards. So, very much that idea that racism, discrimination is happening, whether or not you name and acknowledge it, but actually doing that, naming it, recognising those issues as the first step to making a difference on wards. So having really clear anti-racism policies, zero tolerance policies, and making sure that that senior leadership teams are accountable for actually implementing those as well. I know I'm on the last couple of minutes here, so yeah, just to flag a couple more in terms of staff wellbeing. So making sure that at a senior leadership level, there are people accountable for raising staff experiences, raising issues around staff wellbeing, and addressing those directly with the board, with executives, and that having a real kind of awareness around EDI and the impact for staff from racialized communities and other minoritized groups. Next slide, please. Just to say, we're doing some future research which is starting later this year. So we are taking the findings from this study. We're adapting an existing model of a team-based model of workplace trauma support to ensure that staff are better supported after identity-based incidents, and we'll be trialling that across wards across England. Next slide. Finally, just to say, please do get in contact if you'd like to be involved with that future work. Get involved, hear about updates from our mailing list and so on as well. So thank you for your time today.
Thank you so much, Kate. Yeah, please, join me in kind of thanking all of our speakers. So Husnara, Jackie, Kiara, Ewan, Kath, Donna, Jules, and Kate, finally. Maybe if we could click off the slides, that would be helpful. So yeah, we're now going to go into the Q&A section. So my colleague, Program Manager Kelly Davis, will read out the questions. If you do have any questions, please put them in the Q&A section or put them in the chat, and then we'll read them out and get your questions answered. So Kelly, over to you, please.
Thanks very much, Jason. The panel members have been very efficient at answering the questions as we've been going along, but I do have one open question here, and this is for Kath Prescott. Kath, there's a question saying, where can we see the roadmap of implementation?
Thanks. I did try and answer that in the comments, but I couldn't seem to get it in.
Okay.
But yeah, so in terms of where we're at, both sites are currently moving into the write-up stage of all their findings and the tools. And I think the one that's being referred to is the audit tool that I mentioned. So we've got the data dashboard specification, the audit tool, and the logic models. So they're currently being finalised at the moment. So we'll be able to distribute those towards the summer. So we'll be able to share those with people towards the summer.
Okay, that's great. Thank you, Kath. A lot of the other questions, or all of the other questions, seem to have been answered. So I don't know if the panel members want to add anything to what they've kind of put in the Q&A at all. Thank you for answering all of the questions related to CQC, Ewan.
Hi, Kelly. Sorry, my camera's just stopped working again. I think
Okay.
it's to do when I turned the camera off when I wasn't speaking. I mean, just for the sake of quickness, is it okay if I speak without my camera on with everybody?
Yes,
yeah, that's
please
fine.
do. Yeah.
Yeah, okay. Yeah, apologies for that. I'm not sure what's happening. Yeah, no, thank you to everyone who's posted some questions in the chat, some really great questions. I'll just give this opportunity to Chris or to Dan if you want to ask anything further based on my response in the chat, if you've had time to read it, or if there's anything else I can add. I can see in the other chat that Peter said, can you remind us when you said the CQC will be publishing its PCREF guidance? So I can respond to that question here as well now, if that's useful. Okay, so just for Peter, thanks for your question, Peter. We don't have an agreed date for when we'll publish our guidance. We're hoping that the guidance will go for its final governance sign-off at the end of April, and then we'll publish it as soon as possible after that. As we said in the presentation, we're then hoping some further iterations of more research-informed guidance will be able to be published as well.
Thank you. And I just noticed there was another question in the chat from Helena Posnet asking about being the strategic lead for PCREF in the Southwest. I don't know if anyone could respond to how colleagues from other areas that weren't being presented today can get involved with PCREF and get involved in the implementation of this work. I don't know if anyone can answer that, please.
I don't know if Hasnara is still on the call, but I know the Mental Health Equalities Programme, so the PCREF steering group, they have a community of practice. So I think it'd be worth, if she's not on the call and able to answer for herself, is contacting Hasnara.
Okay, we've just had 2 more questions, Jason, so I'll pose them to the panel members if that's okay. So there's one here. I'm particularly interested in experience of this work in more rural areas where inequalities are evident and arguably could be greater. Are there any insights at this stage, please, or opportunities to look at this? So this is in more rural areas. Would anyone like to? Kath, would you like to answer that one?
Yeah, I can answer it with, and again, in the absence of Hasnara, who would be able to answer it much better than I can. We haven't, as part of the MHIN work, been working in those rural areas, but I do know that there is a mental health trust as part of one of the community, the PCREF community of practice. So again, I think the message again would be to get in touch with Hasnara and be able to link up with those PCREF early adopter sites.
Okay, great. Thank you, Kath. So another question, are learning disability wards included in the research?
No, they have not been included in this research. This research was specifically looking at implementation of PCREF across two sites, so not within this piece now.
Thank you, Kath. Would you like to add? Oh, no. Okay, so outside of the CQC work, where will PCREF sit in the future with the abolition of NHSE?
I'm gonna defer to, I'm gonna say Hasnara and Jackie are people that would be able to answer that question from NHS England, but I think they've had to leave the call at 12 o'clock, it seems like, so apologies for that. What I can commit to doing is maybe following that question up with them both and providing that afterwards.
Okay. Thanks very much, Kath. So the next question is, I'd be interested if any insights into the specifics for carers at this stage. It'd be reassuring to hear from a triangle of carer colleagues that PCREF has made those links. So would anyone like to answer that question?
I know of work that Hasnara has been doing in terms of that triangle of care. And again, that is included and they've made those links. I don't know if that was in one of the earlier slides that Jackie presented, and making sure that PCREF is integrated into all of those different areas. And I know that it's been integrated in there as well.
Okay, that's great. The final question is from Ruth, just thanking everyone for the presentations. And I think the question here is, we need to focus on our professional groups as a way of supporting our local PCREF aims. Do you have any tips on how to approach this and things to avoid? So this is quite a general question for tips.
Sorry, could you repeat that question again?
Yeah,
I was reading something else in
yeah.
one of the other comments.
So it's quite a long question, so it's from Ruth, but I think the actual question is, we need to focus on our professional groups as a way of supporting our local PCREF aims. So could you share any tips on how to approach things and what to avoid?
From my experience and the work that we've undertaken in terms of the research, it would be putting the patient, it sounds obvious, the patients and carers right at the centre of this. So working with your local community partners and people within your local community to actually co-create these processes and look at looking at the data and intelligence and the insight that you get, and making sure that people within those communities are able to reflect on that to really identify what are the activities that are going to kind of improve those outcomes. And yeah, so putting them at the center of it would be the tip. And what to avoid is not taking the time to co-create and just doing. It takes a lot of time and effort to do the co-creation work properly, but it pays off in the long run.
That's great. Thank you, Kath. Would any other panel members like to share their tips and what to avoid at all? No, everyone's very quiet. So, okay, so I'll just go on to the final question then, which is, will the abolition of NHS impact any of the work mentioned today?
It's not going to affect the work that we're doing in terms of the research and writing up. That's still going to be there. My understanding is that PCREF is absolutely still going to be central for trusts and ICBs to implement, and CQC is still going to be inspecting on that. Yeah, so from my understanding, the implementation will continue.
Okay, that's great. Thank you, Kath. Anyone else like to add to that at all?
Can I just mention, Kelly, sorry, it's Ewan speaking, I know you can't see me, is that I don't have any information can share today about the NHS abolition from CQC's perspective. Our approach is just what's been published on our website, but we have put out the slides. If anybody wants to contact us, please do reach out, and if you've got any further queries outside of this call, we can try and support them. I'm just mindful we're running out of time, if that'd be useful.
Yes, that would be very useful. Thank you, Ewan. Okay. Anyone else like to add to that at all?
The only thing that I'd like to add, when we do send the slides out, we can look at some of these questions that might not have been answered. So some of the ones that maybe Jackie and Husnara will have been able to answer them, and send those contact details out. I think that would be quite useful.
Yeah, that's great. We'll certainly do that, Kath. Okay. So if there's no further comments, I'll hand back to Jason to conclude.
Thanks, Kelly. So yes, it's been a really thought-provoking morning session today. I've certainly learned a lot. It's great to see all these system partners coming together to try and improve things for people. Yes, I believe this is the last in our series of webinars. So thanks for joining today. Yeah. Go well. I think the sun is shining in London at least. So if you can get outside, have a bit of lunch, take a bit of the sun rays. So lovely to see you all. Thanks for joining, and goodbye. Thank you.